Good afternoon, everyone, and welcome back. In this final plenary session of WISH 2016, we'll be hearing from one of the brains behind the artificial intelligence company DeepMind and from the Qatari Minister of Public Health. But first, the global diffusion of healthcare innovation. This is something that's been at the heart of WISH from the very start. And for the latest report, data from 6 countries was collected and studied. The idea was to ask the question, where do practitioners look when they or their patients are faced with clinical and organizational problems? And the idea was that by understanding this, you would start to get a much better idea of how to encourage the uptake of valuable innovations. Now, these could be anything from a checklist for the first 7 days of a baby's life to an app providing decision-making support for clinicians to the replacement of surgical mesh with ordinary mosquito netting for hernia operations. Just a few examples of what we mean by innovation. It's clearly a pretty broad definition. But we'll be discussing all of this with our panel, and I'm very pleased to welcome them all. Dr. Don Berwick is the President Emeritus and Senior Fellow at the independent US-based organization, the Institute for Healthcare Improvement. Dr. Krishna Udayakumar leads many initiatives at Duke University and is head of global innovation at Duke Health. Dr. Sanya Nishtar is founder and president of HeartFile and a former government minister in Pakistan. Dr. Ahmed Mohammed Obaid Al-Saidi is Oman's Minister of Health. And Dr. Greg Parston is Program Director of GDHI and has been involved in all of the reports so far, including this one, Greg, which perhaps I can begin by asking you to tell us about. What was different about what you were trying to do this time?
Thank you, Michelle. The GDHI stream of work has been going on now for 4 years, funded by the Qatar Foundation. And what we've been trying to do throughout that period is take a look at the factors which are facilitating rapid uptake of innovations. We know that innovations take a long time to move from the bench to the bedside, and particularly to be used across whole systems and transform delivery of care and patient experience. Last time we were at WISH, we presented case studies which showed how successful rapid innovations could take place. Since then, at Imperial College, we've put together a team led by Dr. Matt Harris, which had more expertise around innovations themselves, particularly frugal innovations and innovations that occur outside of high-income countries. And what we wanted to do in particular this time was to take a look at what it is that causes people to look for innovations, and to ask where they look, in what places they look. The emphasis in research on diffusion of innovation to date has been very much on the supply side, including our own work. But this is uniquely, we think, on the demand side. You know, where are the needs for innovation being presented? Who is looking? Where are they looking? And so with Ipsos Mori, we conducted a study of over 1,300 frontline clinicians in 6 countries and interviewed 90 health executives and leaders in those same countries to try to get a better understanding of that.
And you found?
Well, we found many interesting things. Some very heartening and some a little worrying. Amongst heartening things is the fact that clinicians, frontline clinicians, are actually being driven by the needs of their patients and by their concerns for quality of care. Now, of course, we'd want them to do that, and we'd assume they'd do that, but in times particularly of real financial difficulty and strain, particularly in countries like Brazil, which we studied, and England, which we studied, to some extent the United States, frontline clinicians are actually looking at what it is that their patients need and what quality of care needs, and looking for ways to improve that through new products and policies and practices. And that was really heartening. The problem is that in those same organizations in which those clinicians work, the demands are often for efficiency and for cost savings at the organizational level. And too often we see an unalignment between the things that clinicians are looking for and the things that their leaders are looking for. And that is odd, given some of the other findings we found about particularly the lack of frugal innovation and the lack of looking at countries which can provide more economic and efficient ways of doing things.
Okay, so, and in terms of where people were looking, you found that they weren't looking very far afield.
Well, it's sort of like if I want to find a new friend, I go to the same coffee shop every Friday morning. Maybe you should start looking at other coffee shops. What we found is that people were looking at the same place. You know, only 25% of people were looking at countries, at low-income countries, for example. In the United States, it was even much lower than that, only 5%. Only 10% of people were looking outside the country at all, and only 5% of the people were looking at industries other than their own. Even though some of the greatest innovations that we've got in healthcare, like the surgical checklist, comes from the aviation industry, the way in which we manage PICUs, these primary intensive care units, is being driven by processes from Formula One. People aren't looking at other industries, they're not looking at other countries, and they're certainly not looking at countries outside of their comparative economic strata.
And your belief is they should, because even if your health systems don't appear on the surface to be comparable, there will be things that the high-income health system can learn from the low-income one.
Absolutely. We know, for example, that in countries like Nigeria, they've begun to use surgical netting rather than, mosquito netting rather than surgical mesh for hernia operations. Mosquito netting is a lot cheaper. The effects on quality are absolutely the same, and yet we're not beginning to pick those ideas up. In countries like Malawi, they're beginning to use the apps much more than iPhone, mobile phone apps to connect with information centers about patients in ways in which we're not doing. That is being imported. That's now in a pilot in California, but we're not seeing enough applications like that developed in countries like Malawi, like Nigeria, like Uganda, that can be used in high-income countries and effectively reduce cost without having any detrimental impact on quality.
So the lesson of your report is that clinicians, health executives, people in general in health must look more widely than they would naturally be presupposed to.
Yes, our strap line is look for the unusual suspect. Look beyond the neighborhood coffee shop. Look at new places, new countries, new experiences, even new industries, because there's a lot going on out there, and much of that can offer solutions that deal with the clinicians' demands for improved quality, improved patient experience, but also their organizational needs for improved efficiencies.
Okay, well, let me turn to the panel and see what they think and also get a sense of their own perspective. Minister, did this strike a chord with you? Do you want to see the health service in Oman look to the unusual suspects?
Well, to start with, I'm delighted to be here. I'm grateful to both Her Excellency Dr. Hanan and my friend Lord Darzi, who is the brain behind WISH and a few other projects. And there are still fragmented views about innovation in healthcare, starting from definitions. For me, anything to help us in healthcare to provide better, faster, safer, more cost-effective care with high quality. That's what we are looking for. Oman is or was labeled as one of the upper middle income, high income countries. And as my colleague said here, we tend to look for ideas for innovation from countries with similar income and also with relation to the healthcare system they have. The UK NHS is basically our model. But we started doing things differently. And we've realized, actually, to improve our healthcare system with limited resources, we need to utilize the younger brains who are in the field. We've started having mass meetings with our staff since 2012. We formed a task force for all the regions, interdepartmental. They assessed the healthcare system in Oman, situation analysis, and we've put a very ambitious long-term plan, 2050, Healthcare 2050, which is flexible and which can be implemented every 5 years in our 5-yearly plans. And I'll give you some of the examples of what happened over the last 4 or 5 years. When I was appointed, the waiting list for knee replacement, for example, in Oman was over 2.5 years, and that was not acceptable by any standard. Today, it is in the capital city, about 6 weeks, outside the capital city, between a week to 10 days. How did we do that? It is not the minister and the team and the headquarters, it is the frontline staff. They came up with ideas how to move the services from being centralized in Muscat, our capital city, to the regional hospitals, and within less than 2 years, the waiting list dropped significantly. Every year since 2013, we have an annual meeting where we encourage the staff in all the departments in the Ministry of Health in Oman, whether they are clinicians, managerials, technicians, to come up with ideas to improve the services, whether in their domain or all over the healthcare. And some of the ideas they came up with and which are implementable and made a huge difference. I don't know about the situation in other countries, but in Oman, unfortunately, this sickness of sick leave is huge. The industry, whether private or government, they lose thousands of days of sick leave annually. And in one of the regions, one health center only managed to reduce the sick leave within less than a year by 76% by their own initiatives. In addition to this, which is related to different communities, they've managed to also reduce the abuse of antibiotics and psychotropic drugs by more than 50%.
Yeah.
My colleague mentioned we always look within the same organization and same healthcare, but I'm glad to say as also recently, over the last year and a half, the largest hospital in Oman, they looked at the oil industry to learn some ideas about lean management. And the success rate there was excellent. I used the Royal Hospital, which is the largest in Oman. In our emergency rooms, 55% of our patients used to wait more than 4 hours to be assessed and seen. Today, as we speak, from 55%, only 11% wait for more than 4 hours.
And that came from a lesson from the oil industry.
From a lesson from the oil industry.
Very interesting. Sania Nishtar, what was your experience either as a practitioner or in government in Pakistan?
In terms of innovations?
Yes, positive or the roadblocks too?
Well, I think when it comes to innovations, you have to look at them in a broader perspective, because sometimes when you throw in the word innovation on the table, people think that you're talking about something technical. But innovation can be of processes, and I think what His Excellency, the Minister of Health Oman, outlined was a very classical example of that, a process re-engineering which reduced waiting time. Innovation can be of partnerships as well. And when you are thinking about innovation at a systemic level, a lot of times you have to exploit synergy between process innovations, partnership innovations, and technological innovations. And when you optimally streamline all three within a systemic innovation, that is where you create something with potential. But the thing does not stop there. Creating something standalone in a pilot setting is one thing, but then positioning an innovation for a broader system and positioning it for scale-up and plugging in the right evaluation parameters within its frame is something that will enable its wide-scale deployment. So my experience back in my home country has been, and more broadly in the developing world, that we tend to think of innovations in pilot settings. And I think that we need to think about scalability right from the very beginning. We need to think about rigorous evaluation right from the very beginning. And it is not enough to create an enabling environment for innovations per se. It is also important to create institutional mechanisms that link knowledge from the innovations to policy and planning, and then all the way back.
You are a candidate for Director General of the World Health Organization. I wonder this point about how much further afield clinicians should ideally look. Is it something you can imagine bringing to the WHO?
Well, let me start with a disclaimer. There is a very strict code of conduct for candidates of the Director General. And we are not supposed to use the opportunity of being a panel to talk about
You're
our
not allowed to campaign.
Yes. So, but I can tell you my personal views about innovation. I think the era of the Sustainable Development Goals is very different from what used to be the norm when the MDGs framed development priorities in the developing world. We really have to think out of the box now. We have to think in terms of partnerships between government, civil society, the private sector. We really need to think about out-of-box solutions. So in terms of your question, innovations really is the key to delivering on the SDGs premise. Okay. So any Director General should embrace innovations wholeheartedly, but not within a siloed approach, an approach that enables their incubation, their establishment, and their eventual scale-up and institutionalization of knowledge for systems building in ways that enable you to deliver on the SDGs.
Dr. Krishna Kumar, I think you should probably explain what you do at Duke Health, because as I understand it, your job is to find those innovations anywhere in the world and bring them to Duke.
That's right, thank you. We firmly agree with the perspectives provided here, and when we have looked at innovation in the ecosystem, see significant challenges both on the supply side as well as the demand side. And I think the work that Greg and the team at Imperial have done in this space has been very groundbreaking in formalizing some of these lessons. And 6, 7, 8 years ago when we started in this space, we recognized that people saw the need for innovation. There was a lot of grassroots innovation that was happening either within health systems or through entrepreneurial mechanisms, but without linkages and not necessarily linked to the needs of health systems around the world. So we saw the need really to create an enabling platform that could serve as a linkage between the supply and demand side. So what we created then was a nonprofit that's called Innovations in Healthcare, jointly as Duke, but also with McKinsey & Company and the World Economic Forum.
And what are the best examples that it has enabled you to find? And from where?
So for us, over 5 years, looking at thousands of examples, we've generated a network of 67 organizations operating in 49 countries. One of the first we brought on board was, in fact, HeartFile, which is one of the many initiatives that Sonia has started that's looking at creative ways of accessing health financing for patients in need. In terms of really leading models, I think the most mature models coming from places like South Asia.
Yeah. I meant in terms of the actual, things or processes, or what did you bring and implement in Duke that you'd seen elsewhere?
Yeah, so some of the work that we're doing is certainly to bring it to Duke, but I think we're taking a much more expansive view of saying how could we help adaptation anywhere around the world. So we've helped and seen, for example, work that has started in South Asia in eye care, where if you look at an Arvind Eye Care or LV Prasad Eye Institute, they're able to do cataract surgeries, which is a fairly simple procedure, but under-resourced around the world. And to do it for $40 in a US context, it would be $2,000. And so we have helped organizations take that from India to Mexico, for example, where there's a significant need. We've looked at organizations that have tried to bring some of those principles back to the US as well.
Don Berwick, I know your work for a long time has been, right up this street. Are we essentially fighting against human nature here? Naturally people gravitate towards what they know best and the people they know best and the comparable systems they know best.
I'll take a scientific view of it. GDHI joins a tradition of science on understanding how changes spread in human systems. It goes back decades. It's quite well developed. And the good news is we have a lot to spread. There's no question there's a lot of innovation going on. But I think if you go back to the core knowledge we have about spread in human systems, we have to use that knowledge. Two examples are the whole concept of spread as something you push out, like you might sell a toaster and plug it in. It just isn't what happens. We're treating a sociologic problem as a technical one. And so I've seen ministers of health who are enraged that a good idea hasn't spread, and they think if they yell louder, it'll get spread. No. And we have the science. We understand, for example, that the population of potential receivers is diverse. There are people that are avid or they're looking for innovations. There are others who'll never adopt them, and you have to have a very textured approach to that population. We understand how to package a change for better acceptability if it's more trialable, more reservable, as Greg's report points out. But we don't do that. I constantly see leaders who just say, it works, do it. And it's just not how it happens. I think, like, when I teach this, I say, how would you spread bicycle riding? Yes, there's a good way to ride a bicycle, but every single child has to learn how to ride a bicycle. And that's what this is like. This local adaptation is absolutely key. The other piece of it that I'll comment on is what I would call senior leader intentionality. There really isn't anything automatic about this, unless, with some exceptions. And so just like a senior leader has to have a budgeting process and a human resource process and a capital development process, there needs to be a spread process. And I think we know quite a bit about what that looks like, but it has to be highly intentional. In my own opinion, there's no one right way. It's multi-channel. For example, we know the places I've seen successful use a combination of things. They might have a campaign, they might have extension agents, they might have a collaborative learning process like you're using. They might use more sophisticated models. There's a wonderful spread model that Rashad Massoud has been really the champion of, which is a wedge spread. It's a fractal model of spread. These exist. So I'd say if we got the science and put it to work, we'd be more successful.
But Greg, am I right in thinking that it seems to me that the diffusion of healthcare innovation depends on the personalities involved at any given time?
Well, in part, that's true, Michelle. We'd like to think as well it depends upon the needs that those personalities are being presented with. But it also depends upon the agencies and facilitators that can help them. Krishna is being typically modest here. In one of the, we looked at a number of curator organizations. These are organizations that scan the environment and try to find innovations and make them available for people. And what we found is that most of them are organized sort of like libraries without librarians. Now, Krishna's organization, in part, is a curator organization, but what they've done, for example, with Basic Needs in Detroit, is they've focused on a specific set of needs around mental health. They've looked for innovations around the world that can help that organization deal with those specific needs, and they've helped them apply it. Now, that kind of stewardship in a curator organization is really important. And if you're an individual and all you're doing is walking into the library and looking around for what's going to help me, you're going to be lost. But if you can have agencies like curator organizations that become stewards and help you address those needs, you can much more effectively pick up what you're needing to do, and you can much more easily spread it across systems.
And Krishna, in that point about making those linkages, what connection were you most proud of, that you really felt that there was a need and you found the solution that fitted it?
Well, thank you for the kind words, Greg. Yeah, I think for us it was really making sure that there was a fit between the problem and the solution. Right? Too often we find innovators or those that are pushing innovation, exactly to Don's point, that if you're walking around with a hammer, the world looks a lot like a bunch of nails. And so they're trying to solve somebody else's problem with a solution pre-formed. So I think it's really important to have a more sophisticated problem sourcing, not just a solution sourcing process that allows you to understand in a nuanced way the needs of the clients, the customers, whether those are health systems or patients or communities that you're trying to solve, and that allows a better matchmaking and facilitation of either a single or a set of solutions that may be most useful. In this process, we understood that across the US, like many other parts of the world, there's an unmet need around access to mental health services and community development. And we worked with Basic Needs, which has put this model into practice in 12 other countries, and did a year-long activity where we looked at many urban areas, rural areas, and honed in on where we thought the best location would be and the best partnerships would be, which turned out to be Southwest Detroit. And they've just received 15 months of funding to move that model for the first time into the US. So we're certainly proud of playing a small role in helping that happen, but I think that's the type of active facilitation that's needed for this to be successful.
But you know, it strikes me that if you go into the gallery here, and it's a room full of people with incredible ideas who are, you know, waiting for someone to seize upon them and think, yes, I want to see that in Oman, or I want to see that in Pakistan, and yet so often it does not happen. Why, Dr. alAwadhi, is that? Because people, government health systems or ministries of health are cautious or unwilling?
Let me first agree with what Gregor and my colleague said here, that the organization who bring up these ideas for innovation, they need to align with the system of the governments, the health ministries, or whatever organizations. One size doesn't fit all. They have to take into consideration not only the income of the country and their healthcare system, also the tradition and values of that country. So health ministries vary between different countries in their policies. I think the obstacles in our region, or at least in Oman, is still the dissemination of information to the public, to the even grassroots. We used to rely on the traditional ways, the mass meetings, and we recently only started utilizing the social media, which are very effective for the younger generation. And we also started asking the public to help us on how to improve healthcare. About 2 years ago, we've opened a call center. And initially, we were bombarded with complaints only about how bad our services were. I don't agree with it, of course, Michelle, but that's what. But then they started coming up with ideas, actually, which is an open innovation. The public started coming with ideas, how to improve the service in this health center. What are they looking for as customers? So there are so many ways of doing it, and and honestly, that these curator organizations, I personally knew very little about them because, as you said, they were merely like libraries and databases, which you go and browse at them, and then leave. But now I've heard something different. I'm happy and delighted and be more than encouraged to work with them.
Can I say that His Excellency also told me about another practice that they've put in place in Oman, which we really recommend and advocate as a consequence of the research, and that is to involve younger clinicians in the process of the searching for innovation. We found that overwhelmingly the search for innovation was being conducted by older clinicians, and many of whom had been in managerial positions. But it's the younger people who are savvy with different technologies, with different ways of working, which we need to actively bring into the innovation process.
But they're the ones without the power, or with much less power.
That's right.
Okay. Sanya Nishtar, I wonder, how you see this, because you've been part of the government in Pakistan. You've also been part of an organization which has inspired others in other parts of the world. Do you think that essentially it's not the creation of innovation that's the problem, it is the diffusion part?
Well, just to build further on your question and what was said previously, why it doesn't happen. And I think you have to look at specific contexts and specific situations. So a lot of times in the developing world, in parts of the world where there are mixed systems, both public and private, when we talk about innovations and the impediments to their diffusion, we're actually talking about successful pilots in research settings and the gap that exists in terms of their deployment in government systems, in public sector systems. Because the private sector is always very quick, is always very avid to look for solutions to maximize their efficiency, to make them more cost effective, to help them scale up. So the private sector is not the issue. I don't want to make sweeping generalizations, but by and large. On the other hand, and coming to your point, when we talk about the impediments to uptake and the impediments to diffusion, it is the research and the pilot settings vis-a-vis the large-scale public sector systems.
So even you could have a successful pilot, everything go very well,
exactly.
And it doesn't go anywhere after that.
Exactly. I mean, the success of pilots and how pervasive they are and what the frequency is a different matter, and I'll come to that in a minute. But the disconnect between the successful pilot and its large-scale deployment in public sector systems where they're needed the most, to break inefficiency, to break corruption, to break leakages and pilferages, and why does that happen? Number one, it happens because there is an inherent disincentive. Because a lot of times when you talk about technological solutions and solutions that will enhance accountability and transparency and efficiency and reduce HR requirements and reduce overheads, it is exactly these kind of innovations that will challenge status quo, and Krishna will tell you in great detail. So even though the decision makers realize that's what's needed, there will be an inherent pushback. Also, to be very honest, there's very little incentive to recast their systems. So on the one hand, there's vested interest. On the other hand, there's lack of incentive.
Yeah.
And a lot of times we see that there are perfectly good examples of innovations, whether they relate to, since we're talking in the medical realm, whether it relates to medical records, or whether it relates to functioning of clinics, or whether it relates to HR accountabilities and management. I mean, those innovations, especially at the technological side and the process and HR side, is no rocket science. But it is just the pushback on their large-scale adoption. In the same city, we see the private sector hospitals adopting them at large, transforming them, making quantum leaps.
So Don, what is the way then to challenge the pushback? There must be examples where the large-scale public sector, has embraced something that's been transformational.
Yeah. Well, first to your question about diffusion. Diffusion is innovation. So, because if Krishna has a great idea and I'm available and he passes it along to me, I have to recreate his idea in my local context. It's all contextual. So that's an important nuance. And when the leadership thinks they can just write the manual and it'll be carried out, maybe if it's a very technical thing, but most of the time not. The leadership issues that take away the obstacles are important. Even listening to His Excellency talk about Oman, the two that you reminded me, one is fear. You cannot have either innovation or diffusion in an atmosphere where people are frightened. People play it safe. And Everett Rogers, the great theoretician here, wrote in his book, the process of diffusion is the process of risk reduction, as people try to become comfortable with something, which means they're going to fail at first. So fear is toxic
But fear of getting it wrong in healthcare is not a bad thing.
Fear, it depends what the it is. Fear that if you try to change a process and it doesn't work, you're going to get hurt by your boss or by the press. It really is tough. People are not fools. They're not going to try. Obviously, in healthcare, we want to put a safety net under the change, and you do that, but we're smart enough to do that. It's the fear that managers create, leaders create, about you must do it right or you're in trouble. If you want innovation to occur, don't. The other cultural aspect that is really crucial and playing out in countries that I work with right now is slack. When I got in this field first, I called the Minnesota Innovation Diffusion Project, which is one of the great fonts of knowledge about this. And I spoke to the director, Andy Van de Ven. I said, well, if you had one suggestion to a CEO to foster innovation, what would you do? He said, slack. The point is, you can't keep doing your work at the intensity of normality and expect innovation to occur. There has to be a reservoir of energy. Right now, in the global context, as healthcare systems get stressed and pressured by cost and scrutiny, the slack goes away and the innovation and diffusion decrease. And you can see that now. I could name countries where that's happening.
Okay, Greg?
Yeah, Don has raised a really important point, and a point that was an important part of the last GDHI report, where we found that one of the key obstacles to diffusion, we didn't call it fear, we called it doubt. But
You called it what?
Doubt.
Doubt.
Doubt is a real strength of clinicians. The fact that I present you with a set of symptoms and I tell you what I've got wrong with me, and you're going to doubt that. You're going to question me. And that same doubt, which is a real strength amongst clinicians, can also be a barrier in their adopting new ways of working or new techniques. But I was struck by something that Larry Summers said today, which is a failure to explain the benefit of looking out. And that's what leaders have to do within the context that Don talked about. We've got to spend more time creating visions and being able to explain the benefits of looking out, of looking at Oman, of looking at Pakistan, of looking at Malawi and Nigeria and Uganda, and the kind of benefits that that could bring. Because if we don't do that, that doubt is going to prevail, and that doubt's going to become an obstacle.
Krishna?
Agree with both of those points. I think leadership and the purposeful way that organizations approach innovation is important to the diffusion and scaling. And I'll add to that, I think it's really important to understand and reform the policy and regulatory and financing ecosystem to create the right catalytic forces that allow the delivery innovations then to take hold and to scale. And so a lot of the complementary work that we've been doing with Mark McClellan here and others is around this concept of accountable care, right? So how do you create the policy environment and the levers that then enable the appropriate innovations to take hold? Because if you're still working in a supply financed environment or in a fee-for-service environment, it's much harder to align to innovations that are focused on creating value, that are creating frugality in the system. So it's really important that the policy innovations and the delivery innovations really go hand in hand to be successful.
Okay, Minister, you wanted to say something?
Yeah, just like to go back to Dan's idea about fear. I think he is right in many ways, and cultural variation as well. So what we need to do actually as leaders in healthcare or any organization to create platforms for our grassroots, for frontline workers, where we can enable them and empower them to express their ideas without being feared about punishment or being fired. I can assure you that in the government sectors in Oman, firing is very, very difficult. Unlike the private sector, Sonia talking about it. And I wish what Sonia said about the private sector is universal, that they come up with initiatives and greater ideas. But in certain countries, including my own, the private sector is lagging behind, very much so. And I think one of the reasons that private sectors in Oman, and it might be similar in the region, they don't come up with initiatives because of fear. Most of the people who are working in the private sector are usually on short contract, expatriate, and they are happy with things as they are, status quo. Even if they've got good ideas, they don't want to express them. The 6 countries studied, one of the points you've mentioned about the communication skills with patients. And if you've noticed, the United States and Qatar were the lowest. Actually, they thought this is an issue that needs to be dealt with. I think the reason is, again, in here, in the region, and I'll talk about Oman only, when you have more than 60% of the healthcare providers don't speak the language of the patient. Yeah. That's in itself an issue. And those who are providing the service also. And Dan, honestly, the fear is, in Oman, I can assure it's not there. But I don't think it is there, but it might be. Somebody who's coming from a different background, different environment, and they are in a system which is strange to them and they are strange to it. We need to open up for them if we want them to help us in coming up with new ideas and new initiatives to make things better. Yeah. So I just wanted to comment on that.
I'd like to go back to the finding about how unlikely it is to look from a high-income to a low-income country. And Don, from that survey, actually, the United States was the worst at looking towards the low-income country. Something like 5% of respondents were prepared to do that. Is that being blinkered? Is that being prejudiced about what a lower income country has to offer? Why is that?
Don't ask me to explain my country right now. I would not try. It's a leadership issue. If you are a leader, and this could be departmental or national, in my view, your behaviors will model the behaviors that will be elicited in the organization. If the leader is authentically curious and begins to ask authentic questions, not fake ones, about, gee, does someone else know how to do this? Or has anyone looked? A cascade begins. Unfortunately, in a lot of leadership systems, the leadership behavior is learned to look like you have the answers, to be smart. And that's not an invitation for scrutiny. The other is the slack issue. For example, I sound crazy, but I will tell you, I would say to an executive who really wants to beef up innovation, buy some plane tickets and give them away. You take that clerk in the ward or that young doctor and give him a plane ticket to Ahmed and have him spend a week there. There's nothing like this kind of reaching out, and we don't do that because we're so pressured, again, with the production system that we don't create the room to look. Yeah. But the organization will behave with respect to innovation the way the leader behaves.
Sanya Nishthar, you were talking earlier about the rewards or the lack of rewards for innovation in a public sector environment. I mean, as Greg said, we're in an era, though, where everyone is feeling the pinch. I mean, that ought to be a reward in itself to be able to save money for your organization.
It ought to be, but unless you create the incentives to enable change, change does not come. And in countries such as ours, the problem, so there is a deeper rooted problem, and the deeper rooted problem relates to the capacity deficit in terms of HR, in terms of the low investments in higher education, in terms of the relative lack of attention to science and technology. I mean, innovation does not happen in a vacuum. A country ought to have invested over a period of time in higher education, in institutions of science and technology, in creating the right institutional architecture to forge the government-industry collaborations, setting up institutional arrangements to systematically channel evidence for policy, knowledge for action. And it is within the context of such an environment that given the right impetus, given the right policy impetus, or the legislative or regulatory impetus, and the right demand, that innovations burgeon. And in the absence of that, just merely creating incentives is not going to create that push. But while we're discussing this, I think we also need to be mindful that the reason why we are seeing a lot of innovation happen in the field of healthcare in particular is because the context has changed. You know, we've seen the disruptive potential of cell phones and the telecommunication backbone and connectivity, which is really changing the paradigm for innovation in countries like ours. And you couple that with demand. You couple that with greater...
So it is happening, despite all the institutional barriers that get in the way. The disruptions find their way through.
The disruptions are finding their way through because there are some enablers, because the context has changed drastically, because technology has really cut across the core of many of these problems, and because there's a great societal demand for change. And because of those considerations, these little pockets of innovations are burgeoning. These little experiments, these little pilot initiatives, these little entrepreneurial efforts are burgeoning. When you couple them with a little bit of catalytic effort and money and a little bit of policy push, they do burgeon. But there is a huge gap in terms of the potential of these innovations to cascade change. And the gap that exists, and I think that needs to be that is what we need to bridge, and that cannot be bridged unless we look at it through an institutional approach.
So they might be disruptive rather than transformational, Greg.
Well, they can be transformational, but only if you allow them to be disruptive. I think that one of the really exciting things when you take a look at what's happening in countries like Pakistan and some of the countries in Africa, the use of the cell phone, the use of drones to deliver pharmaceuticals. You know, these are really disruptive things that could bring great benefits, not just to their own countries, but around the world. And yet, because of the things that Don and Krishna were talking about, we neither have the regulatory incentives to look afield, nor do we have the ability to break down the fear and to really challenge the way we're doing things. And maybe some of the prejudices that stop us from looking at countries that aren't our own and say, gee, if we did that, yeah, it would disrupt things, but my goodness, wouldn't that be better for patients? Wouldn't that be better for our organization? Wouldn't that be better for our system?
And just to quickly add on that, I think we shouldn't just think in the project mode, the tech, the cell phone and the project mode when we're talking about innovations and the potential of innovative solutions to cascade broad-based change. I mean, what about big data and how it can transform health and development in general? What about new discoveries in science and technologies and new therapies in non-communicable diseases and the massive potential that has?
Krishna?
Yeah, so I agree that context matters, and I do see the small disruptions happening. The challenge is they're completely fragmented. And even when there are solutions, even if they reach scale, are done in a fragmented way. And so you have lots of wearable devices and apps and telehealth solutions, many of them built around specific health areas. So there may be a fantastic solution that works for diabetes, a different solution that works for hypertension, a different one that works for a third health condition. And what we're not doing is actually building around patients, communities, consumers. So if I'm a consumer that has hypertension and diabetes, is it really that I need to follow two separate pathways in two separate solutions? I think a lot of what's still missing is the integration of multiple point solutions that enable a much more patient-centered and community-centered approach.
Yeah. Don, I wonder what you think about the pace of change, where it is happening, the change, the disruption, the innovation. Where it is happening, I'm imagining, or at least hoping, that it must have picked up because the world around us is changing so quickly. The younger clinicians who are coming through are used to a world where, you know, everything is being made as simple as possible for us. I mean, their workplace shouldn't be the one place where they have to step back in time.
Yeah, I agree with that. I think the game might be changing because of what Krishna and you were talking about. You know, when I got first interested in innovation, we didn't have the web, and people certainly didn't have iPhones. Something is new here, and in fact, just visit the exhibit hall here. Walk those booths of these people, few of them over 30, it seems to me, they're just breaking through to all new possibilities. The whole field, the field that excites me the most right now, really for game changing, is telemedicine. I just sense this is it's going to make us dinosaurs faster than we ever thought, and it's going to happen in this many entrepreneurs producing good things, some of which will survive and thrive. Krishna's challenge about do we have the mechanisms to sort the wheat from the chaff, or to sort the proposed innovations into the buckets where they can help. I don't think we do. I'm not sure how formal that should be, Krishna. We should really have a way to help that.
Let me, on that note then, about what the game changer is. I mean, you said telemedicine, but I wonder if I could ask everyone else to close what you think the single thing is that's going to enable the global diffusion of healthcare innovation. Minister, what would you say?
Well, if you allow me only a few seconds actually to just carry on for what they started. All of you trust your mobile phones to do all your banking transaction, many businesses. And yet, if we talk about virtual healthcare, there's still very little going on in reality. But as you said, you walk around only the gallery here, there are lots of ideas. And we're still talking only about telemedicine, but there's huge potential for using IT to help us to provide healthcare in not only remote areas, cheaply and more hopefully accurately. What I'm trying to say also at the end of this, that we need to empower and enable our younger generation to unleash their capabilities to help us in healthcare, the grassroots, to help us to make things better. As you said, Greg, they have probably more time as well and better ideas how to work with technology. And if we utilize their ideas, their initiatives, we can do things only better. Thank you.
Okay. Sania Nishtar, what would be a game changer for you?
Well, for me, the game changer would be personal digital devices for individuals and the potential that has to bring about individual behavior change towards health-seeking behaviors, and secondarily, for that to influence the behavior of communities and institutions towards better health. I think there is huge untapped potential there, and we need to systematically reap that.
Okay, Krishna?
To me, I think it's all about empowering people. Right? We get caught up in the technology. The innovation's not the technology, it's how you deploy it. At the end of the day, most of healthcare is about people. Most of what we spend healthcare dollars on are health workforce. So empowering individuals to be changing their behavior, to be co-producers of their health, empowering community health workers and physician extenders, and lots of ways that we can task shift and task care. I think there's a role for technology to enable those, but really until we get the human capital piece of this right, the technology isn't going to solve it.
And Greg? What would be the game changer for you?
Well, particularly now, I hold two passports, a Brexit passport and a Donald Trump passport. And in a time when societies are seeming to become more introverted, and thinking of the audience of leaders here, the big game changer for me would be ministries that are open. Ministries that are open to ideas and are looking afar to new ways of working, to challenges to their own ways of working, and to ways to improve that think outside the box.
And just finally, Don, I suspect you've got something else you want to say, but I also want to ask you, because you've seen the evolution of GDHI over the course of WISH's existence. What should it look at next? Because it's looked at the supply of innovation, it's looked at the demand for innovation. What's the next step?
What should GDHI be looking at? I think I'm so enamored right now of the democratization of knowledge and capability. I think the game changer is people will have in their hands the ability to do things for themselves, to take care of themselves. I'm not talking about financial burden or shifting skin in the game. I'm not talking about that. I'm just talking about democratizing care itself in a way we don't even begin to imagine. And I think, I hope WISH, I know WISH will be looking ahead to that new world. The hospital, the visit, the doctor even will become far less relevant than we think they are right now. I think that might be right. You're going to hear it now in our next plenary. When you hear Mustafa talk about DeepMind and how it can kind of leap over the normal textbooks and teach us by asking questions a different way, I think it'll change the world. And I know WISH will be there. WISH has already taught me more about that than any other source.
Okay. And on the point about younger practitioners, I'm pleased to say that we have a young doctor, a junior doctor, and a future pharmacist as part of the closing panel, where Dr. Hanan Kawari will also be speaking, the Qatari Minister of Public Health. So we still have that to come. For now, I'd like to thank my panel all very much indeed. Thank you.